So, inborn error of metabolism are also known as inherited metabolic disorders. So, these disorders can occur because of enzyme deficiencies, receptor deficiencies, transporter deficiencies, and cofactor deficiencies. We need to understand there are different biochemical pathways in our body. So, whenever there is defect in these biochemical pathway, or there is a defect in the cell transport, or receptor level, or because of any cofactor deficiency, the inborn error of metabolism takes place. Till date, there are around 1,902 inherited metabolic disorders or inborn error of metabolism are described. The inherited metabolic disorders are broadly categorized into three major categories. The first category is small molecule disorders, second category is complex molecule disorders, and the third category is energy deficient. So the small molecule disorders, majority of this disorder they present at birth or soon after birth in neonatal or infant life. The second category is complex molecule disorders. So complex molecule disorders present later in the life because most of these disorders occurs due to accumulation of end products, accumulation of some products in our body, such as lysosomal storage disorder, because the degradation pathway lysosome is affected. So lysosome is not able to degrade the compounds in our body, and they get accumulated in our body, and the symptom present later in the life. Similarly, with energy metabolic disorders, the age of presentation can vary from the early life to late life. The presentation of inherited metabolic disorders can be of two types. First is acute presentation and second is chronic presentation. If we talk about acute presentation, so they can present in acute emergency. And whenever a doctor is evaluating these patients for acute emergency, cause of acute emergency, they were not able to figure out the exact cause, such as sepsis, trauma, cardiac events, and they are not able to identify the cause, etiology of that symptoms. So I will give an example. Such as few patients present to us with present to us with encephalopathy. So in encephalopathy, they present with altered level of consciousness. Whenever we evaluate these patients with routine investigations, usually we don't find any defect in normal tests, the routine test. And if you do MRI, sometimes we change non-specific. Sometimes we find non-specific changes, or sometimes it can be normal. So in these category, parents and doctors should have a suspicion of inherited metabolic disorder. And the second category is chronic category. So this is the largest category. The chronic presentations can be such as developmental delay, intellectual disabilities, movement disorders, or they can have organomegalies, they can have cholestasis, jaundice, they can have cataract, they can have hearing deficit, so they can have epilepsy, which responds poorly to the medical treatment. So these disorders can present in a chronic manner. So parents should, whenever parents are finding that their baby is not doing well and not growing as expected, then they should consult the doctor with the underlying possible inherited metabolic disorders. So second important is autistic-like presentation. So these days we are seeing this surge of autism, and almost recent data suggests that around 2.8% is the prevalence. Out of 100, we are getting 2.8% with the autistic symptoms. And there are 200 different metabolic pathways that can get involved in the autism, which are described till today. So they should also get evaluated for possibility of underlying neurometabolic disorders. Clinicians should have very high index of suspicion. And there is a major shift in recent years in the understanding of the pathophysiological pathway. So I will give an example. I had a patient with intellectual disability and dystonia. Dystonia means he had a raised tone in his lower limbs. So when I evaluated this patient, so his neurological symptom was not fitting into a described phenotype. So then I evaluated that patient and I found that patient was suffering from GM1 gangliosidosis. So that patient presented to me at a 14 years of age, and parents were having no clue that that patient can have an underlying metabolic disorder. So the key was I tried to look for underlying pathophysiological pathway which is affected in this particular patients. So one more point I want to bring here, that if any clinician is finding a patient with multisystemic involvement and that multisystemic involvement is not explainable by common disorders such as sepsis, malignancies, immune immune related disorders, rheumatological disorder, then they should think for a possibility of inherited metabolic disorders. Like few patients present with the eyes involvement in the form of cataract or retinitis pigmentosa, brain involvement in the form of developmental delay, then liver functions, there is a bony abnormality. So then they should think for possibility of underlying inborn error of metabolism. So the point is, if we are getting a patient with multisystemic involvement that doesn't fit into the common disorders, then we should definitely think for inherited metabolic disorders. So the test which can be done for to identify a patient suffering with inherited metabolic disorder ranges are categorized into different categories. So first is routine routine biochemistry test and routine blood counts. So, like in the second category is radiological imaging, and the third category is enzyme test, enzyme assist, and molecular genetic testing. So, if we will talk about the routine tests, so among routine tests, like we are sending CBC. So, if patient is having aplastic anemia picture, have low counts with low platelet counts, so starting from the very basic test like CBC, CRP, liver function test, electrolytes, and TMS, plasma amino acid acyl carnitine, urine organic acids, ABG, blood gas analysis, pH is very, very important. Then next important is radiological test. So radiological test, MRI, X-rays, like in majority of mucopolysaccharidosis, we can see the dysostosis multiplex, that is changes in the bone. So in radiological images like MRI brain, we can see changes of the white matter degenerative disorders, combined white matter and gray matter degenerative disorders. We can figure out the changes. And the next is enzyme assist. So enzyme assist we can send if we are having very high index of suspicion for some lysosomal storage disorders. So enzyme assists are available. We can send enzyme assist. And the next is molecular diagnostic tests such as whole exome sequencing, single gene testing, gene panels like epilepsy gene panels. So by doing these tests, we can reach to the diagnosis. Apart from these, I want to stress here that newborn screening is also available in many part of the country now. So newborn screening is a way by which we can identify these disorders in early life, in neonatal period. We can send the sample between 2 to 7 days of life, and we can get tested for the many small molecule disorders in newborn life itself. So before 2019, it was very difficult to categorize these patients into different categories because the clinical features were so overlapping and we were primarily dependent upon the lab testing reports. But after 2019, it became very simplified because there was a paper which was published in 2019 that was a clinical approach to identify inherited metabolic disorders. So after this publication, so it was extensive document, extensive publication, and in that publication they categorized these disorders based on the clinical manifestation. So nowadays, me with my team, we are able to identify these disorders clinically, and whatever diagnosis we are keeping, and surprisingly, we are getting that at more than 80 to 90% of time we are correct in diagnosing the patient. So, like a small molecule disorder, complex molecule disorder, and energy deficient disorder, these are three broad categories. But among a small molecule disorder, there are two categories. One is a small molecule accumulation disorder, and second is a small molecule deficiency disorder. So I will give an example. Small molecule deficiency disorders includes protein metabolic defect, glutamine synthesis defect, asparagine synthesis defect. So these manifestations, because these are very important amino acids for a even brain development and the other parts of the body organ development. So whenever patient is suffering with these disorders, they have onset of symptoms in intrauterine life. So, like serine synthesis defect patient can have a microcephaly at birth. And whenever we are doing that neuroimaging, we can find the malformation of cortical development with difficult to control seizures as a clinical manifestation. So, then we can identify that this patient is probably suffering from serine synthesis defect, and surprisingly, it's considered as a treatable disorder. We just need to give a high doses of serine to these patients, and they show very good response to the treatment. So there are few case reports which are available online. So the patient which were identified at birth suffering with serine synthesis defect and treated, they had a very good neurodevelopmental outcome at the 6 month of age. So similarly, in complex molecule disorder, there are three different categories. First is complex molecule accumulation disorder. Second is complex molecule deficiency disorder, and third is cell trafficking and transport defects. So in this category also, we can identify them clinically. Like uh, like complex molecule accumulation disorder, they present with the core spatial features, organomegalies. Complex molecule deficiency disorder, they have a different clinical manifestations. We can identify they present late, the chronic presentation, and like multiple exhaustosis. It's a GAG synthesis defect, glycosaminoglycan synthesis defects. And third categories is cell trafficking and transport defects. So these patients present with developmental delay, intellectual disabilities, movement disorders. So nowadays, with this classification, 2019 classification, we are able to identify these disorders on the basis of clinical presentation. But the problem is with the awareness, because the training of inherited metabolic disorders is not included in the medical curriculum in MBBS, even in MD courses. Now gradually these residents are developing interest in inherited metabolic disorder, but there are very few teachers across the country, those who can treat, those who can teach the students to identify these disorders. I want to tell you about the broad categorization depending upon the clinical manifestation. So, depending upon the clinical presentation, out of these 1,902 described inherited metabolic disorders, 80% of these disorders present with the brain involvement. So they come under the category of neurometabolic disorder. Around 10 to 15%, I will say 15, more than 15% patient present with the metabolic liver disease. So they have a liver disease which was not identified by extensive other testing, other testing like Wilson disease. They present with acute hepatitis, but not able to identify with the routine testing. And very few clinicians have a very high index suspicion for Wilson disease. But nowadays the awareness is raising, and many clinicians are able to identify the metabolic liver disease because of Wilson disease. Because the carrier rate of Wilson disease is 1 in 90. It's too high. It's very high. It's very high. So you can estimate that how many people across the country are carrier of Wilson disease. And whenever they get married with a person who has having same gene defect, there's 25% risk of having disease in their progeny. So I want to cut it short. So whenever a patient is suffering from any unexplained neurological illness, so they should be evaluated for possibility of inherited metabolic disorder. And whenever a baby is suffering from liver disease, and we are not able to identify the cause of liver disease, even after doing the infectious panel, viral illnesses, some bacterial illnesses, UTI, and other causes, or biliary atresia, then we should think for a possibility of underlying inherited metabolic disorder. So these are two broad categories. So neurological symptoms can be of different type. That can be a hypokinetic movement, that can be hyperkinetic movement, that can be tone disturbances, they can have developmental delay, they can have intellectual disability, they can have epilepsy, they can have autistic features, they can have hyperactivity. Like Sanfilippo disease patient present with hyperactivity. So they don't have any other manifestation apart the major clinical manifestation is hyperactivity. Few diseases which are not under having brain involvement or liver involvement, they can present with the bony involvement, like Morquio disease. So Morquio disease patient can have a bony involvement. They can have a spinal problems, problems, and few disorders they can involve mainly heart, like Pompe disease. So Pompe disease patient can have only cardiac involvement. So so the first point is, if any clinician is getting a patient with who has having unexplained neurological involvement, he should think for a possibility of underlying metabolic disorders. Similarly, if patient is having liver disease and not able to identify the cause, he should think for a possibility of metabolic disorders. These are commonly missed. Okay, so there are few disadvantages if we are not able to identify the disease at right time. So the most important disadvantage is we are not able to prevent the recurrence in subsequent pregnancy. That is the biggest disadvantage, because like I already gave the example of complex molecule accumulation disorder. Many of those disorders presented later in life. So they present after 3 years, 4 years, 5 years of age. So by that time, the family has already having a second kid, and there's a very high likelihood, very high possibility of having same disorder in the next baby also. Like in autosomal recessive disorder, there is a possibility of 25% recurrence in next pregnancy. So that's the major component, because in any country, if the affected population with inherited metabolic disorder is rising, it's a huge economic burden for that country, that state, and for family. So the most important point is prevention of recurrences in subsequent pregnancy. So we need to have a very high index of suspicion, and we should identify these disorders. And second is definitely on the quality of life of the patient, because as the disease progresses, the systemic involvement, multisystemic involvement becomes more, and they can have a poor quality of life, and they can have a shortened lifespan. So identifying these disorders early can have a we can prevent the disability and death in families, and definitely we can limit the symptoms. First is the correct identification of a correct diagnosis or correct identification of the underlying genetic defect. So that is first and foremost point. If a baby is suffering from a genetic disorder, that patient should be identified with what gene defect is he or she is carrying. Second is fetal medicine consultation. So fetal medicine colleagues are very important, because they can do amniocentesis or chorionic villus sampling, and they can send the sample for a prenatal diagnosis. We can identify the disorders in subsequent pregnancies by prenatal genetic testing. And if family is willing, they can terminate the pregnancy, or if the baby is normal, they can continue the pregnancy. So that is a very important way. But for that, the first patient, the index child, should be correctly identified. So what disorders he is carrying. So right, sir. So genetic testing is nowadays it's available at many centers, but it is not possible to do genetic testing for a very wider range of conditions. It's not possible, because the trained geneticists are less in the country. I think not more than 100 across the country. Those who are practicing clinical genetics, and the key to get a get a appropriate report is defining the phenotype. So whatever symptoms we are writing on our prescription while ordering the genetic testing, that is very very important, because in genetic testing they apply filters, various filters. So like microcephaly, I'm mentioning that the patient is suffering from microcephaly, developmental delay, cataract, dystonia. So these symptomatology is very, very important. If any clinician who is not writing the symptomatology clearly, or he is missing something, very there is a very high likely that we can get a erroneous report. So so that is very important. So So first of all, I think it's not possible to order genetic testing for a very wide range of symptoms till our clinicians are more well versed with the clinical phenotype. So there is a term that is HPO terms. HPO terminologies are human phenotypic ontology terminologies. So these terminologies are very, very important. Whenever we are writing our prescription and we are ordering the genetic test, clinician should be well versed with these terminology. He should use the appropriate terminology. Then only the report will be more reliable. So first of all, we should clearly communicate about the disease, its pathophysiology, and its possible complications. So parents should be prepared, mentally prepared with the possible complications also, and what steps they should take in case of emergency. Like in small molecule accumulation disorders, these patients present with intermittent symptoms like propionic acidemia, methylmalonic acidemia patient, they remain normal. They remain normal with some limitations, with some symptoms, and whenever they are having any intercurrent illness, during that intercurrent illness, they go into catabolic state and they land up into the emergency department with encephalopathies or acidosis, fast breathing, and other seizures, other manifestation. So, so it's very important to give an emergency letter to all of these patients so that whenever they are having symptoms or they are having emergency, they can reach to a nearby hospital. And the doctor, if they are not very well versed with the inherited metabolic disorder, but they will come to know about the disease and what treatment should be given during the emergency. So, emergency letters should be given to all these patients so that in emergency, the treating doctor can know about the treatment and symptoms. And second important issue, second important is support groups. The role of support group is very, very important because there are very few clinicians across the country, and the number of patients is very high, very high. The number for in different estimates, the number can be up to 1 to 2% minimum, but it can go up to 4% if we'll able to identify all these patients out of total population. So number is very high. Like national policy for rare disease clearly mentioned that 6 to 8% of the population is estimated to suffering from one or other rare disorders. So there are around 7,000 rare disorders. Out of these 7,000 rare disorders, uh, around 1,900 disorders are inherited metabolic disorders. So number of inherited metabolic disorders is very high, and it's not possible to get a expert help every time, each and every time for these patients. So the role of support group is very, very important because the parents of a patient, they understand disease very well, even more than clinicians. So they can support. There are few groups like in Jaipur, there is a group, Merd India. They are supporting many such kids, and they are supporting. They are giving financial help also. They are providing medical foods also to patients suffering from inherited metabolic disorders in Jaipur. Similarly, there is an organization, Rare Disease India Foundation. They are also helping the kids suffering from different lysosomal storage disorder in identifying their needs and providing them help. One more organization, ORDI, is also working in this area. LSDSS, Lysosomal Storage Disease Support Group, is also working in this area. So these organizations are very, very important because they can fill the gap. So they have their own, they have their websites, and Merd India, they are having their WhatsApp group also, and they are available on the website. They are having their
Okay.
own website also. So there are different modes of treatment. Like for lysosomal storage disorder, the enzyme replacement therapies are available for few disorders like Hunter, Pompe's, Fabry. So for these disorders, the enzyme replacement therapy is available in India. For few disorders, enzyme replacement therapy is not available in India, but it is available globally. But these therapies are not easily available, easily accessible, because of cost. Few other disorder like a small molecule accumulation disorder category, we have medical foods. Medical foods are available, special diets are available. If a patient is suffering from a particular amino acid disorder, so that amino acid can be removed from the diet. So metabolic dietitians are very, very important. So they can guide the families by changing the dietary patterns, and they can advise them special medical foods. Drug repurposing. Drug repurposing means these few drugs which are already available for some different indications, but they are found to be have useful effect in few other disorders also. So that is known as a drug repurposing that are not tested in that particular disorder. Like I want to give an example. I had a patient. That patient was having some mitochondrial defect, and mitochondrial defect, that patient, when I searched the literature, I found that a drug which is available in Indian market and that costs only 900 rupees per month for family, that is developed for some other particular indication, but that has shown a very good response in these patients. So I advised that drug, and that patient is now on 2 month follow-up, and that patient is showing significant positive response. Similarly, I had a patient with autism, and that patient has autistic feature with hypertension. So I evaluated that patient at 3 years of age, and I found that patient was having gain in function mutation of one of a calcium channel receptor. So it was a receptor defect, so it comes under a category of inherited metabolic disorder. When I searched, I got a calcium channel blocker that was specific for that particular calcium channel, L-type calcium channel. So I advised that drug to that patient, and that patient saw significant improvement in his symptoms. So drug repurposing is a very, very, very big category. So this category, so whenever I want to advise the clinicians, whenever you are getting a patient with confirmed diagnosis, you should search the literature, and you should look for some drugs which can have a positive impact by altering that pathophysiological pathway. So pathway-based treatment. Next category is cofactors. So cofactors are easily available, like in biotin deficiency, we have biotin which is available. Pyridoxine-dependent epilepsy, pyridoxine can be given. So there are different categories. We can use these drugs like hydroxycobalamin shows very good response, and these are easily available, and these are not very costly. And the next category is gene-based therapy. So which are under development across the globe. There are 450 different gene therapy trials are ongoing across the globe, and CRISPR-Cas9 is also under development. mRNA-based therapies, modernized working on few organic acidemia and trying to develop mRNA-based therapy for these patients. One company, PTC Therapeutics, they are trying to develop a drug for cystic fibrosis, methylmalonic acidemia for a particular mutation. And like for cystic fibrosis, there is a drug which is available, Trikafta, it is already marketed. So in cystic fibrosis, majority of patients, we have seen that there is a cell trafficking defect. So receptor is formed, but it has not reached to the surface. So by giving Trikafta, we can improve the quality of life. And with recent literature, it is seen that 90% of cystic fibrosis patients show positive response with Trikafta. So these are different modalities. Apart from these modalities, few other surgical modalities are also important. Like few of inherited metabolic disorder patients present with dystonia. So we can send them for physiotherapy or injection to these patients, and we can improve the quality of life of these patients. In 2014, I did my training in genetics, and then I applied for training in inherited metabolic disorder at MD University School of Medicine. I was very lucky that I got the opportunity to go to that university, MD University School of Medicine, Atlanta Department of Human Genetics. That was an amazing department, and they were far ahead than any institution in our country. I learned so much. So then I developed interest. Uh, I I never thought that I will enter into this area. And when I came back, I returned back to my parent institution, that is SMS Medical College, Jaipur. So we were seeing a lot of patients. It's the second largest medical school in country, and the hospital in which I am working is JK Hospital. we are having around 1,200 to 2,000 patient OPD per 24 hours. That's huge. And almost 80 to 120 indoor patients per 24 hours. Out of these patients, I was able to identify many inherited metabolic disorders. So I'm working as a associate professor of pediatric medicine in the department, and the patient which are coming from for some pediatric illness, so we are identifying these disorders in these patients. So gradually, our clinical knowledge is growing. We have a very good team with me. We have a pool of 120 residents working in this institution, pediatric residents, 40 per year. So we are having huge team. We are having many senior residents, medical officers working with me. So gradually we developed the clinical acumen, and now we are able to identify these patients clinically. So I never thought, but this is really a challenging area and growing area. So I'm searching daily. Daily, I'm searching for the recent literature, recent developments in this field, and gaining more and more knowledge. So most important, which we are finding is that by teaching the residents. So we are teaching our residents, and we are having interdisciplinary clinic also in our institution, like few disorders present to ENT department. I will give an example. So I had a reference from our ENT department for otitis media surgery. So when the patient came to me, I examined that patient and I called to the consultant that this patient is suffering from Hunter syndrome. So that clinician told me, ENT clinician told me, what is Hunter syndrome? I told him this patient is having Hunter syndrome. It's a lysosomal steroid disorder, and you can operate that patient for otitis media. But after the operation, you send that patient to us, and we'll start the enzyme replacement therapy for this patient. So after a few days, 15 days, I got a call from that consultant that I'm sending a Hunter syndrome patient to you. So that was so interesting. Even after a single discussion, he was able to identify the Hunter syndrome patient, and we are getting a lot of patients from our ENT colleagues, and they are diagnosing it Hunter syndrome. So the key is interdisciplinary discussions, because a lot of ophthalmologists, they are getting patients with cataract or corneal edema, and majority of these patients are suffering from one or other inherited metabolic disorders like retinitis pigmentosa. So in our institution, there are around 960 faculties are posted in different departments. So our institution is running a multidisciplinary teaching program every month. So in that we accumulate together and we discuss these sort of cases. So and second is residents teaching and training. So we are taking class for residents regularly. So we have a daily class schedule, and whenever these residents are going out of our institutions, they are getting spread across the state and across the country. So they are carrying this message. So that is one of the most effective way which I am finding interesting. And second is by online programs, but the attendance in online programs and conferences, it's very difficult to it's very difficult to have a very good attendance. In the majority of online teaching programs, I have not seen attendance more than 100.
Okay.
But the UG class which we take, we are sensitizing them. We have 250 students as an undergraduate each batch. So whenever we are taking classes on inherited metabolic disorder, we are sensitizing a lot number of patients. And in India, the problem is very few clinicians are having habit of reading. So they don't read much. Basically, they are not spending their time in reading recent advances. So I think it's a bit difficult. Still, we are organizing few conferences and we are organizing some CME lectures, and we are trying to sensitize more and more number of people. So cascade screening is very interesting. If, for example, in a family there are three brothers, and first brother, he is having a kid suffering uh, from a autosomal recessive disorder. So it means his wife is also a carrier. So his wife is also a carrier, and he is also a carrier. So the baby had a autosomal recessive disorder. But that this father has two more brothers, they can also be a carrier, and their wife can also be carrier. So cascade screening means we can identify all the family members, those who are harboring that gene defect. So in these patients, we can do prenatal testing, and we can identify whether their kid will having the genetic disorder or not. Second important is there is a new test which is available across the country, that is couple carrier screening for genetic disorders. So we can do couple whole exome sequencing or a couple carrier screening even if they are having a first kid. So there's no genetic defect in a known genetic defect in family, but still, if family want to know because they had a friend who had a kid with some genetic defect, we can do couple whole exome sequencing for these families also. Policy for rare disease 2021 was launched in 2021, and in that policy government has dedicated funds under Rashtriya Arogya Nidhi. So central government is supporting 50 lakhs to each patient who is suffering from genetic disorders, and very soon I think government will increase these fund. So, and they will include more number of disorders under treatable category. Second is crowdfunding platforms. So Rajasthan government has launched a crowdfunding portal Raj Sambal, and government is trying to raise funds through some charitable organization or CSR funds in Raj Sambal, and that funds can be used for treatment of these rare disorders. And few organizations like ESI, railways, army, they are supporting the families by giving the funds, or by providing the medications, costly medications.